Welcome, everyone. Thank you for joining us today for the report launch titled From Silos to Synergies, Integrating Non-Communicable Disease Prevention and Care into Global Health Initiatives and Universal Health Coverage. I'm Ilana, and I will be your technical facilitator today. For assistance, please use the chat function to message anyone with the title Technical Facilitator in their name. Before we get started, I have a few technical notes to explain. If you would like to contribute a perspective, idea, or thought, please use the chat function. If you would like to ask a question, please use the Q&A button. You can find both of these features at the bottom of your Zoom window. Please note that this session will be recorded for documentation purposes. Spanish language simultaneous interpretation is available during this session. The feature has already been activated and is available by clicking the interpretation button at the bottom of your screen, where you can select the language that you would like to hear. Since there will be one speaker speaking in Spanish, I recommend you to choose the English channel if you would like to keep listening in English throughout the whole event. En esta sesión, dispondremos de interpretación simultánea en español. La función ya se ha activado y está disponible haciendo clic en el botón Interpretación en la parte inferior de la pantalla, donde pueden seleccionar el idioma que les gustaría escuchar. For those of you just joining us, welcome and thank you for attending the report launch today. I will now pass the floor to Ms. Katie Dane, CEO of the NCD Alliance. Katie, the floor is yours.
Thanks very much, and welcome everyone to today's media briefing for the launch of the report From Silos to Synergies, Integrating Non-Communicable Disease Prevention and Care into Global Health Initiatives and Universal Health Coverage, jointly produced by the NCD Alliance and the Leona M and Harry B. Helmsley Charitable Trust. My name is Katie Dane. I'm the CEO of the NCD Alliance, a civil society network with over 300 members in more than 80 countries, dedicated to improving NCD prevention and care worldwide. And I'm really delighted to be moderating today's event. As mentioned just now, the media briefing is available in both English and Spanish, so please select your preferred language by clicking the interpretation button at the bottom of your screen. I'd also like to remind everyone too that this is an on-the-record media briefing, so all comments by our speakers today are for the public record. So let me start by briefly outlining the run of show for the next hour. We'll start off by myself making a few introductory remarks before introducing our panelists, who will each speak briefly. After that, we'll then open the floor for questions from our media representatives attending today. In order to ask a question, please send your questions via the Q&A tool at the bottom of the Zoom platform. And please do indicate which media outlet you are from and whom the question is directed to. If you'd like to ask the question verbally, please feel free to raise your hand on Zoom by clicking the raise hand button at the bottom of your screen, and I'll come to you. If you wish to speak in Spanish, please also indicate this in the tool before we call on you. And again, please do indicate which media outlet you're speaking from and who you'd like to direct the question to. And also, please do keep the questions short so that we can get around as many as possible within the hour. If we run out of time during the course of this media briefing, you can of course follow up via email with your questions. Please contact Michael Kessler at NCD Media Relations to set up a time to speak to one-to-one with any of our speakers or ask any of your follow-up questions. With those logistical points, I'd like to start the media briefing with a few comments to give some context to today's briefing. This media briefing is taking place as part of the annual Global Week for Action on NCDs, held this year from the 6th to the 12th of September this week. The Global Week for Action on NCDs calls on everyone everywhere to get involved in reducing the burden of NCDs and increasing health and inequalities around the globe. Now in its fourth edition, previous years of the Global Week for Action have seen more than 11 million people from over 100 countries participating in all different ways through the week. For example, we've seen individuals and organisations raising awareness on NCDs in their communities by working with the media and different events like group walks. We've seen people reaching out to their governments to demand stronger action on NCD prevention and control. And of course, a huge amount of activity around social media, especially in the last couple of years due to the COVID-19 pandemic and virtual ways of working. For this fourth edition in 2021, the Global Week for Action has focused on a specific theme, and this year it is on the theme of community engagement. We decided on this theme because we believe that if we are to mount an effective public health response to the world's biggest killer, NCDs, we really need to ensure that people living with NCDs are recognised as indispensable partners across policy development, programme and service design, implementation and monitoring and accountability. We have seen over the last few decades how successful this approach has been in the HIV/AIDS response and in more recent times in TB. So of course, we're keen to build the same sense of community engagement and involvement to improve NCD prevention and control around the world. The importance of community engagement in the NCD response has always been a very important part of our work at the NCD Alliance. For many years now, we've been actively encouraging meaningful involvement of people living with, of patients in forums, in policy development, as well as engaging people living with NCDs as spokespeople with the media, for example, today at this very briefing. So it's no coincidence that today's media briefing comes during the Global Week for Action, as we're launching two important resources that have a very specific focus on strengthening communities. The first one that we'll be covering today is called From Silos to Synergies, Integrating NCD Prevention and Care into Global Health Initiatives and Universal Health Coverage. This report focuses on the importance of breaking down disease silos in global health and really reorienting services to be people-centred and to be integrated. And this has become even more so relevant in light of the lessons learned from COVID-19 over the last 18 months and the way that we have seen so many health systems buckle under the pressure around the world. And as always in global health crises, it's low and middle income countries that are feeling the most devastating effects. Yet currently most of the healthcare delivery in these countries does not truly reflect the growing burden of NCDs there. Diabetes and hypertension, for instance, are becoming as big a threat for health authorities in South Africa as HIV is, and just as big a concern for families. Comorbidities between infectious diseases and NCDs are also becoming more and more entrenched. People living with HIV have a significantly higher risk of cardiovascular disease and some cancers, for example. And people living with TB are much more susceptible to diabetes and vice versa. So it's clear that we need a healthcare model that's much more integrated, and it's our hope that our new report, From Silos to Synergies, will help move forward the impetus to implementing these changes within health systems around the world. Nina Renshaw, who is NCD Alliance's Policy and Advocacy Director, will be outlining shortly the main findings of the report today. And we'll also be hearing from Guru Sorensen, who is on the front line of integrating HIV and NCD services in Ghana, as well as Sally Agalo, who lives with both HIV and NCDs in Kenya, and Jaime Barber, who lives with an NCD and will be providing crucial lived experience perspectives today. The second resource that we are launching this week at the Global Week for Action is the Global Charter on Meaningful Involvement of People Living with NCDs. As I mentioned earlier, NCD Alliance's engagement with communities, with people living with NCDs, has been a central priority for us for many years. And I'm happy to say that the Global Charter was built through a very extensive consultation with nearly 500 people in 50 countries, half of whom were people living with NCDs. The Global Charter was developed with the aim of ensuring that people living with NCDs are meaningfully involved in every step of decision-making that affect their lives and their health. So what do we mean by meaningful involvement? It's when governments, it's when organisations, it's when institutions really recognise the value of the community and lived experience. And why it's important is that we have learned over many decades from HIV/AIDS, TB and disability that when policies, programmes and services are co-designed with communities, they are much more likely to be relevant, appropriate to the needs, scalable and essentially sustainable. For people living with NCDs, it ensures that we hope that it will ensure that they are actively involved in all aspects of the NCD response, from governance to policy making, to design and implementation of programmes and services and monitoring of those programmes and policies. Essentially, what we're talking about here is nothing about us without us. Now, through the Charter, we're calling on organisations, governments, institutions to publicly endorse the Charter and commit to fundamental principles and 10 core strategies of what we see being crucial to meaningful involvement of people living with NCDs. As I've already said, these strategies will really enable the involvement of people living with NCDs in decision-making at all levels. We've seen lots of high-level commitments in the past decade to promoting meaningful involvement of people living with NCDs, and we really hope that the Charter will build upon this crucial momentum. So I'm looking forward to hearing today from both our speakers bringing lived experience, Sally and Jaime, and their thoughts on the Charter. So with that, with no further ado, let me pass over to our first speaker, my colleague Nina Renshaw, who is NCD Alliance's Policy and Advocacy Director, who will share with us some of the highlights from the report on integration, and also reflect more broadly on what integrated health services might look like going forward. Over to you, Nina.
Thank you, Katie, and welcome everybody. Pleasure to be here today to present the findings of our new policy report. We commissioned the report to the George Institute for Global Health, and it was supported by the Helmsley Charitable Trust. As Katie was saying, clearly we can't speak about health challenges today without putting the conversation in the context of the pandemic. COVID-19 has shaken the foundations of health systems and economies everywhere, and people living with NCDs have been at the epicenter of this crisis everywhere in the world. The vast majority of the millions of people so far who have lost their lives in the pandemic had underlying health conditions, and what we mean by that is largely non-communicable diseases, so most commonly hypertension, cardiovascular disease or diabetes. Studies have estimated that between 60 and 90% of COVID-19 deaths have been people living with one or more NCDs, non-communicable diseases. And it's indisputable that governments and global institutions are facing what's known as a syndemic, that the acute pandemic of COVID-19 is compounding the impacts of the chronic pandemic of NCDs that was already present in our societies. It's also sadly very clear that government's long-standing inaction on NCDs has amplified the human cost of COVID-19. People living with NCDs are experiencing now the collateral damage of the pandemic because health systems are being severely disrupted everywhere. Essential health services have been postponed or delayed or are simply not available at the moment. Health systems and workforce have been redeployed as necessary to respond to COVID-19, but the toll from the postponed treatments, for example, for stroke, cardiovascular, kidney disease, or delayed diagnosis for cancer, supply chain failures for essential medicines like insulin, suspension of palliative care, mental health services, rehabilitation services. The toll of that could well be far bigger than the toll of COVID-19 itself. It has been estimated that the death toll so far of the pandemic is double the number of people who have died from the virus. That difference is explained by several factors, including that delayed and deferred healthcare, increases in mental health conditions, increased alcohol and drug use, as well as potential over-reporting of deaths from the virus as well. COVID-19 has really brought home the fact that globally health systems are inequitable, inefficient and underfunded. With NCDs, even before the pandemic, now being the primary cause of disability and premature death worldwide. Low and middle income countries are experiencing a rapid transition from disease profiles which have been shaped by infectious diseases and maternal and child health conditions to actually now being dominated by NCDs. Last year, the Lancet NCDI Poverty Commission highlighted that 1 in 3 diseases affecting the poorest billion people in the world are now NCDs, and half of these are affecting children and young adults. And even before the pandemic, less than 20 countries worldwide were on track to reduce the Sustainable Development Goal for NCDs. That's SDG target 3.4, to reduce premature deaths, so that's deaths under 70 years, from NCDs by 1/3 by 2030. And one of the main reasons for lack of progress towards this target since 2015 is an absolutely chronic lack of investment. Astoundingly, less than 2% of global health financing is directed towards NCD prevention and care around the world. And this is compared to NCDs being, the major driver of death and disease worldwide, and these days 7 of the top 10 causes of death around the world. The vast majority of global health funding is still directed to the health priorities of the Millennium Development Goals, so namely HIV/AIDS, TB, malaria, and maternal and child health. So this is the context of the policy report that we're presenting today, From Silos to Synergies. The global health and development communities have for too long overlooked NCDs or still understood them as rich world issues, which is really not the case, or dismissed NCD care as too costly, and certainly ignored the interconnections between the target populations, people living with HIV, TB, malaria, and women and children's health, and the reality of the epidemiological shift to NCDs, and also to the extent to which those populations, those priority populations, overlap. And that's still reflected in deeply entrenched silos in global health programs and funding. And it's really a barrier to developing countries adapting to real health needs. So the research report takes the stance that this siloed approach in global health is really counterproductive to treat all these diseases in very separate programs. We asked the researchers from the George Institute to look at how policymakers, how health systems and the global health community can respond better to the needs of people living with NCDs in low and middle income countries, recognizing the reality that people living with HIV, people living with TB are more susceptible to many NCDs, including diabetes, cardiovascular disease, chronic lung disease, and several cancers, as well as mental health conditions. For example, in South Africa, the government has confirmed that half of people living with HIV are also seeking care for NCDs. But far too often, as we'll hear from Sally later on, access to healthcare for NCDs is more limited than that for HIV, TB, or maternal and child health conditions. So unless NCDs are integrated into existing health programs, these will continue to reduce people's quality of life and undermine the treatment gains in other disease areas, which have been fantastic over recent years, for HIV in particular and maternal and child health as well. But we're risking, because of the overlap of people living with multiple chronic conditions at the same time, we're risking that the same people, the same target communities of those programs are suffering and dying unnecessarily from preventable and, very importantly, treatable NCDs. It's over a decade now since Ministers of Health got together and resolved to encourage the development, integration and implementation of vertical programs, including disease-specific programs, as they said, in the context of integrated primary health care. So exactly what we're talking about today, making sure that the NCD needs of people living with different health conditions are also taken care of. But progress in that area has been far, far too slow, to the extent that world leaders confirmed in June this year a new target in this area. They met for a UN General Assembly high-level meeting on AIDS in June 2021 and committed their governments to ensuring that 90% of people living with HIV and at risk of HIV can access care, healthcare for NCDs and mental health conditions by 2025. So our policy report, we asked the researchers to look at how governments can deliver on this commitment by 2025. They did that by undertaking an online survey of close to 200 people, consulting experts and stakeholders, a review of the literature, and gathering 3 really excellent case studies of where this has been done well already at the moment. They looked first to identify the barriers to integration, and they found that there's remaining political or organisational ambivalence as a major barrier to establishing new ways of working. One of our interviewees told us that the health system in their country has systematically neglected NCDs at all levels. There are powerful groups who receive donor funding and have done for a long time and resist any change to the status quo. And this was really powerful. They told us right now, the people who are left behind stay exactly where they are. And this is exactly what we're trying to tackle with this report and in our advocacy work. Programs are often struggling, the researchers found, to gain the necessary support from management. The old ways of organising teams in very disease-specific or program-specific ways are still very dominant in some of these countries, and are a barrier in themselves to the new models of care that would integrate NCD services. The stakeholder consultation also found that health systems are fragmented, that there are weak systems of referral for different conditions, even when the patient is the same person, that there's an inability to follow up patients with different conditions, a lack of clinical guidelines, that the frontline health workers who are so essential to this response receive very little support, and that medicines and supplies are either unaffordable or inadequate in terms of their availability locally. A NGO worker in the Philippines told us these services are only available in selected project sites or in target communities, and have not yet covered a majority of NCD patients in the country. So on a pilot basis, on a project basis, there's some availability, but these integrated models of care are not yet sufficiently widespread. So many people, the majority of people, continue to miss out in terms of their real health needs. The study went on to identify the benefits of integrating care. Ultimately, we want to get the message about the benefits across to policymakers and to global health donors working in these contexts. Firstly, integrated care can increase access to specialist care for groups who are otherwise not receiving the treatment they need. They can, importantly, increase retention and effectiveness of care for both HIV and NCD patients. They can reduce the disease burden and the impact of those diseases for those accessing health services. They can increase detection and diagnosis of NCDs among groups living with other conditions. Obviously, as you'll know, early detection and diagnosis is absolutely essential to give the best possible prognosis for treatment and maintain the best possible quality of life. Also, integrated services, really importantly, increase satisfaction of people seeking healthcare. They increase the satisfaction of the user and the trust in services, and therefore make it far more likely that people will stick to their medication routines and stick to the recommendations of their health providers. And all this leads to integrated services having the potential to be far more cost effective. Although in that vein, the researchers found that far more studies are needed on cost effectiveness. So this is an area for future research. We looked in terms of where the integration of services is currently being done well. The researchers from the George Institute found 3 excellent case studies. From Zambia, we looked at the cervical cancer prevention program, which is a national program run by Zambia Ministry of Health and Center for Infectious Disease Research, which is supported by PEPFAR, the US agency, US Centers for Disease Control, and the University of Zambia. We also looked at the Integrated Chronic Care Clinic, which is run in a district of Malawi, run by the Malawi Minister of Health, supported by Partners in Health and the Global Fund to Fight AIDS, TB, and Malaria. And thirdly, a program from Western Kenya integrating HIV, AIDS, and diabetes care, which is run by the Kenya Ministry of Health, Moi University and Hospital, the AMPATH Consortium of North American Universities, and has widespread support from several organizations, including the World Bank, USAID, US National Institutes of Health, CDC, Bill and Melinda Gates Foundation, AstraZeneca, Boehringer Ingelheim, Lilly, Merck, Pfizer, and Takeda. You will find the details of all of these case studies in the report and a brief synopsis in the policy summary briefing that you've received. If you haven't received those, please drop us a message and we'll make sure, send us your email, we'll make sure you receive those directly. Finally, the report makes a number of recommendations, both to governments, to global health donors, development organisations, and to us, to non-governmental organisations. And we can group these into 4 areas of recommendations. Firstly, amplify the voices of people living with NCDs, put the experiences of people and listen to their needs centre stage, involve them in health systems design processes, and provide a platform for them to share experiences. Secondly, forge stronger relationships. It's essential to create buy-in amongst disease-focused groups and stakeholders, communities and donors. This is key to making our efforts to integrate them sustainable and long-lasting. Thirdly, integrate in programme design at the programme design stage already with a strong vision for whole of person care, so corresponding to a person's needs, especially those with multiple chronic conditions, and people-centred health systems. And finally, all of these are of course really relevant to the COVID response and recovery context, but make sure we're strengthening health systems overall with a focus on primary health care, shift towards integrated data management systems, effective referral pathways, and a skilled and well-equipped, well-resourced workforce with the supplies and medicines they need to respond to the needs of the patients. So in conclusion, our aim for this report is that it will support countries in working towards resilient, sustainable and person-centred health services to respond to the needs of people living with multiple chronic conditions, which is increasingly common in every setting around the world. We're aware that this year and far beyond should see rapid investment in health systems worldwide as countries are continuing to grapple with the pandemic. We remind you that over a quarter of the world's population are living with 1 or more NCDs that put them at higher risk of COVID-19. So this is a really key opportunity to learn the extremely painful lessons of the pandemic and further strengthen health systems, provide sustainable person-centered care for everybody and make the necessary investments. NCDs can no longer be neglected in response and preparedness for future health threats. And the key to recovering stronger is to keep populations in better health in the first place by ensuring that NCDs are more effectively prevented as well as diagnosed, managed and treated. So thank you for listening this afternoon, and I welcome your questions later on. Really looking forward to hearing the other panelists, and I'll hand back to Katie. Thank you.
Thanks so much, Nina. So we'll go straight to our next speaker. Our next speaker is Guru Sorensen. Guru is head nurse at the International Healthcare Centre, IHCC, in Accra, Ghana. The IHCC began, I understand, as primarily a HIV service for men who have sex with men, but has over time evolved into a centre that delivers a variety of health services encompassing both infectious disease and non-communicable disease, which we'll hear about today. Over to you, Guru. We can't hear you. No, we can't, still can't hear you. No, I'm still not hearing.
Katie, may I suggest coming back to Guru in a few minutes? Maybe we can go with Jaime or Sally first.
Yeah, sure. So we'll circle back to Guru whilst we get the sound sorted on her end. So let's then move on to our next speaker, who is Sally Agallo. Sally is a person living with HIV and NCDs and is based in Kenya. Today, Sally will reflect on the report as well as the global charter that I mentioned at the beginning, as they affect her own story and life. So over to you, Sally. Thank you.
Thank you so much. Hello, everyone. It is evening in Kenya. It's a cold evening in Nairobi. So I am Sally Agalo. I'm 52 years old. I know a lot of women don't like talking about their age, but I'm very proud because of what I've gone through. I almost died in the 90s with HIV, and there was no treatment. It was like COVID now. But I thank God that I survived and I was able to live. But this wasn't easy because there was a lot of intervention that had to be done, especially with my mental health, because I attempted suicide. I'd lost 2 babies. I suffered a lot of stigma from my husband and my in-laws. And I later on, now being a patient advocate, I realized that these people did not have information. So for me, information is power, and I'm glad that in this week of the Global Week for Action on NCDs, our own government in Kenya today, we had a webinar in the morning, and they are keen to empower and work together with communities to reduce the burden of NCDs in our country. So for me, information is power. I would say that, for example, as we are talking now in this webinar, if we had someone who had maybe is blind or is not able to hear, how would we handle that? So are we also going to involve these people, because we are saying leave no one behind? So I realized that a lot of people, being a patient advocate, I realized that a lot of people are dying because lack of information, and that is what brings stigma. My husband left me when I was diagnosed with cervical cancer, because he couldn't live with a woman who could not give him babies. So you can imagine a man running away because of that, and he didn't have information of how he was going to handle me. And after that, I also got an ostomy because I suffered colorectal cancer as well. And right now, I'm living with a stoma bag, and a lot of people don't know how to handle me. I remember when I had the bag, I had to stay at home for 6 months because my colleagues didn't know how to handle me. My employer didn't know what to do with me, my family. So for 6 months, I was in the house, and you can imagine the psychological bit how this affected me psychologically. So I must say that training is very important in all aspects of these NCDs. What really helped me is what we call treatment literacy training, which was a model that we borrowed from South Africa. At that time, I was working with Medicines Sans Frontiers. And if that model can be borrowed for all NCDs, it would be a very good thing. And again, as I've said, let's leave no one behind. If we have people who are blind, people who are not able to, who are dumb and deaf, we should also train more people who can take care of these people. Again, the issue of disclosure comes because they have no choice. Their condition has to be known, whether they like it or not. So again, a lot of patients are losing their lives, not because of the diseases, but because of the care that they're not able to get. Another thing is the cost of treatment is very, very expensive. A doctor's room is the only place that you cannot bargain. But if something can be done about that, that would also be a very good thing. Otherwise, I'm glad and I'm honored to be one of the panelists in this webinar today. Thank you.
Thank you so much, Sally, and for sharing your own story and personal experiences. I'm sure we'll come back and have more questions for you at the end. So let me try and go to Guru again. I think she's logged back in. So over to you, Guru.
Hi, Katie. Can you hear me now?
Fantastic. Yeah.
Excellent. Okay, then good morning and good afternoon and evening to all of you. It's a pleasure having an opportunity to be on this panel. So yes, my name is Guru. I'm a nurse working with the International Healthcare Center in Accra, Ghana. As mentioned, our main focus or target population at our facility is people living with HIV. However, we are a general clinic open to all Ghanaians, general population, and we provide a wide spectrum of healthcare services. So we do provide services for NCDs, people living with HIV, TB, and so on. I think the main core of our work is that we all have integrated services. So any person who comes to our facility despite the diagnosis they come in with or the diagnosis they live with, they all go through the same flow at the facility. They are all seen by the same staff. They are all seen from the same consulting room, and they all pick the medication at the same pharmacy before they go home. So we have fully integrated services. We also have, since the beginning, have a focus on as a client-centered care. So each and every client is seen as an individual, and we try as best as possible to satisfy the need and the wishes of these clients. Now, when it comes to the integrated services and why this is working well for us, I think that as a service provider, we can't just see one part of the health needs of an individual. We need to see the holistic view and provide holistic care. And when these services are integrated, so we are providing services for all kinds of conditions from basically one department, it is easy as a service provider to provide full care for the client and satisfy all those needs. It also helps us to make sure adherence is in place. So in case for a client who comes to us, who basically come to us because of the HIV status the person has, but then we are also able to take care of the hypertension this person is having or the diabetes this person is also having, and we can make sure that any challenges or complaints this person is having, we can make sure that we take care of those challenges without having to say that, no, for us, we will provide you with the HIV medication, but then you need to go to this department or this other facility for treatment for diabetes or hypertension. So we are able to provide that full care of the clients. Then also looking at how it benefits our clients, we are basically a one-stop shop for all the health services that this client need. It makes it much more convenient. Secondly, they also meet with the same staff every time they come. So instead of having an appointment date at one facility for the diabetic medication on a Monday, and then on Friday they will go to another facility for the HIV medication, they know that they can come to IHCC and they can get all the medication they need only every once in a while where they have an appointment. So I think that is helpful. We also are fortunate to have the opportunity to work 6 days in a week. So if you come on a Monday or you come on a Saturday, you know that the people you meet at the facility, they can make sure that they can provide you all the care that they are seeking, it being only for hypertension, or it being for malaria, or it being for STIs and so on. So we are able to provide the full aspect of health services whenever we are open and to any population at all. I think I read the report myself and have learned a lot, and I am very grateful for the work that's been put into it. And I know that for myself and my colleagues here at IHCC, we can benefit a lot of this. One thing I took note of, which is something that within actually the past few months, we have had some debates here how to go about it, is in terms of some of the newer ARVs that has come that we are putting most of our clients on these days. We do see that it has an impact on people's weight. So we see clients who are stable in terms of HIV treatment, and they are with suppressed viral load, and they are doing perfectly well. They might not have any NCDs now, but we fear that due to some of the effects of the ARVs they are taking, they are having an abnormal gain weight, which we fear that could lead to these possible NCDs later on. So I think this is why the focus on this work now, which the report is making very clear, that is more important now than it has ever been before. Because if we don't have integrated services now, we need to make sure that this comes in place, because I foresee that maybe in some few years to come, the need will be even more than what it is today. Yes, I think that is what I wanted to say. Thank you very much.
Thank you very much, Guru, for that and for sharing the experiences of IHCC and the great work you're doing on integrated holistic services for people in Ghana. now we go to our final speaker today, and as I said earlier, after this we'll then go to Q&A, so please do add your questions to the Q&A chat at the bottom there, and we'll come to them in a minute. Our final speaker today is Jaime Barber, a person living with an NCD based in Mexico. Delighted to have Jaime join us, and he'll be sharing with us today his perspectives on both the reports that are being launched this week. Over to you, Jaime.
Muchas gracias. Quisiera que imagináramos una fábrica de bicicletas donde quisieran ganar una carrera, que se empeñaran en construir la mejor bicicleta, que invirtieran en la mejor tecnología, los mejores materiales, los mejores ingenieros, y al final no tuvieran en cuenta al ciclista. ¿Ustedes creen que esa bicicleta podría ganar una carrera? Difícilmente. Así, cualquier sistema efectivo de salud debe tener como base y como centro a la persona y a la comunidad. Debe escuchar nuestras experiencias, nuestras necesidades para dar una respuesta efectiva. Me llamo Jaime, soy mexicano, vivo con EPOC, ya soy exfumador. El tabaco ya me enfermó de por vida. Vivo igual que las personas con obesidad y hasta con las personas que tienen diabetes, con el estigma de autoprovocarnos o autoinfringirnos nuestra enfermedad. Tengo, como muchos, una enfermedad no transmisible y conozco a muchas personas que sufren todos los días por nuestra condición, la diabetes, la hipertensión, el EPOC, otros que viven en diaria hemodiálisis esperando el trasplante de un riñón, otros que luchan contra el cáncer. Además de ocuparnos por nuestra condición de salud, tenemos que luchar todos los días por recibir el tratamiento, la atención o las medicinas. Algunos tomadores de decisiones pretenden creer que no existimos o se nos trata como un tema resuelto o como daños colaterales y no tenemos importancia en la agenda. Tristemente, ahora con el COVID salimos a la luz pública, salimos del tapete donde estábamos ocultos de la peor manera posible. Las personas con hipertensión, con diabetes, los fumadores, hemos contribuido a aumentar la mortalidad por el COVID. Sabemos que nuestro pronóstico será grave o muy grave y la mayoría de los casos, si nos contagiamos, ahora que somos más visibles, que estamos en el ojo, es cuando menos servicios de salud tenemos. Por ejemplo, el hospital donde me atiendo es hospital COVID 100% y ya tengo 18 meses que no tengo ninguna atención médica o me puedo checar en este hospital público. En octubre del año pasado fui positivo a COVID. Gracias a una detección temprana y una atención médica temprana que tuve que gastar de mi bolsillo, tuve solamente síntomas leves. Sin embargo, psicológicamente sí me afectó mucho porque tenía pánico de empeorar cada día. Decía, ya sobreviví, pero cada día estaba sobre mí la angustia de enfermarme más gravemente, tener que recurrir a un hospital, morir aún ahorita. Después de 6 meses tengo secuelas del COVID que me deja no al 100% o a mi condición anterior. Algunos compañeros exfumadores han muerto estos meses, unos por COVID, como Roberto o Luisa, que desgraciadamente fueron catalogados con una enfermedad preexistente y no recibieron la atención médica oportuna que requerían. O muchos otros como Ana María por falta de servicios médicos y los medicamentos necesarios para la atención de una enfermedad como es la hipertensión. En mi país, ya lo decía Nina, durante la pandemia se han muerto algo más de 500,000 de personas, más de lo que esperado. Y de estos muertos de más, 250,000 poco más han muerto por COVID. ¿Y cuántos? Casi la otra mitad han muerto por falta de un medicamento, por una enfermedad no detectada, por una cirugía pospuesta, a la falta de un tratamiento. ¿Cuántos por falta de una cama de hospital y cuántos más que no llegaron al hospital por miedo a no contagiarse y no enfermar? Según los datos de la OMS, las enfermedades no transmisibles son el factor de empobrecimiento número 1 en el mundo, debido a los costos del tratamiento, a que generan incapacidad laboral, a que son enfermedades largas y que generan gastos cada vez mayores al ir evolucionando. Estas enfermedades hacen que se gaste el patrimonio y se hipoteque el futuro de generaciones de familias enteras. Si el COVID ya cambió al mundo, necesitamos cambiar nosotros también. El informe que hoy se presenta y la Carta sobre Cobertura Universal, en la que nosotros, personas que vivimos con una enfermedad no transmisible, participamos activamente, debe ayudar a cambiar los sistemas, a redirigirlos y centrarlos en las personas y en las comunidades. Como decía Gurú hace un momento, como una persona con una enfermedad no transmisible les decimos fuerte, ya basta, no más. Hacemos un llamado urgente a nuestros gobiernos para garantizar el derecho humano a la salud, que apruebe las leyes que garanticen una cobertura universal de salud, que exista una verdadera rendición de cuentas, que garantice la cobertura universal de salud como una realidad y no como una ley de aplicación incompleta y discrecional. Las personas que vivimos con una enfermedad no transmisible debemos correr en una bicicleta, a veces con los pedales muy chicos o muy grandes, otras en una bicicleta muy pesada, a veces no cabemos. Recuerden que para nosotros nuestra bicicleta siempre pesa. La distancia es muy larga y siempre vamos cuesta arriba. Tómenos en cuenta. Muchas gracias.
Thank you so much, Jaime, and for sharing your own experiences and the very real challenges of receiving access to treatment and services and regular health checks during the pandemic and continuing to be like that. So we've now heard from all of our speakers, so thank you all for those great presentations. And now we open it up for questions from journalists. As I said earlier, please do add your questions to the Q&A tool at the bottom of your Zoom platform. Indicate which media outlet you're from and who you'd like to direct the question to. If you'd like to ask the question verbally, please raise your hand on Zoom by clicking the raise hand button at the bottom of your screen, and I'll come to you. If you wish to speak in Spanish, please indicate that before we call on you. And as I mentioned earlier, please do keep the questions short. I've seen a couple come in whilst our speakers have been presenting. I think the question from Esther from Uganda has been responded to by Guru about what are the new ARVs causing weight gain. The other question that I think has come up a couple of times already is, can we have access to the report and the press release? And the answer is yes, we'll be sending the report and the press release out as soon as the media telebriefing ends to everyone. And I think there have been a couple of requests for follow-up interviews with some of our speakers, and we'll be sharing contact details with you all and putting you in touch after this media telebriefing. I'm not seeing any specific questions, so let me just ask one while perhaps a couple of questions might come in. Let me ask a question to Nina. Obviously, the report focuses on, integration from silos to synergies, focuses on integration of NCD care. And obviously a lot of the conversations we've been having today have been around the COVID-19 pandemic. How do we really ensure that the COVID-19 pandemic is a turning point for integrated services, and that we really do see an end to these silos in services in many countries?
Thanks, Katie, for the question. I think with the UN high-level meeting on HIV a couple of months ago, we saw that the political realization is there. The penny is dropping, that people don't exist in the same silos as the funding does, and that the services need to be integrated. And it was really very instructive to hear that from Guru's experience as well. That you're seeing this on the ground. You're seeing that there's many comorbidities and complications, whether that's from the other chronic conditions themselves or from the treatment regime. So this is a kind of a useful realization and a useful reality check to hear that on the ground from Ghana as well. I think where we need to go from here is to, as I said, the researchers found that there's a need for more studies around the area of cost effectiveness. So we know from speaking also to policymakers that there's an understanding that most people actually with NCDs now are living with more than one. Most people with other chronic conditions like HIV and TB, as we said, they're going to be more susceptible to diabetes, to hypertension, to cervical cancer in the case of HIV, and that needs a policy response, and that we have to invest in it. So the issue is, okay, how much is this going to cost? How do we integrate these services in practice? So I think the study that we've undertaken here, or the study rather that the George Institute has undertaken, is a real starting point. There is some skepticism that needs to be dismantled about how we do this better. So what the report does really well is to actually draw out from real experience on the ground, as I said, from 200 interviews and from surveys with countries where these programs are in place, draw out what those real world barriers have been. Why has this not happened so far? The political commitments have been in place for more than 10 years already. So what are those barriers? And then how have those 3 case studies that we picked out from Zambia, from Malawi and from Kenya, how have they actually systematically tackled them to deliver better person-centered care that speaks to the needs of the patients? And I mean, there's a real equity question there that you see, I mean, like Sally's case, where there's an inequity in care, where people are experiencing that they have better access, higher quality treatment, more availability of medications that they need for certain conditions. And then others, may not be picked up early, they may not be screened for and diagnosed early enough, and then the medications may not be available even when they are picked up, or there may not be specialists available in those countries. It's these kind of bottlenecks and system failures that we need to look at, and we need to work with the other health programs. We need to work with the Global Fund. We need to work with, we saw in those 3 case studies, there's been excellent support from external agencies. How can we do that more systematically across all those programs to make sure that they're responding to the real needs of the populations that they're serving? And then let's be honest, they've done an amazing job, particularly in HIV, maternal and child health and TB. But there's so much more to do if they really want to respond, not just to the diseases, but to the people living with them. I'll leave it there. Thank you, Katie.
Thanks, Nina. And one final question before we wrap up to Guru. I wanted to ask, obviously, IHCC is a great example of this integration of services and a holistic approach. How are you seeing it on the ground in Ghana in terms of the change of disease burden there? Are you seeing a rise in NCDs, and how is that interaction happening?
Yes, I don't have the statistics to share now, but we do see, we obviously see an increase in people's weights, which definitely we know that this is a clear indicator that diabetes and hypertension and other cardiac diseases is also at a higher risk. So yes, we do see a trend, and not only to say that this is because of the ARVs or because there are lifestyle changes, diet is also changing. And I'm speaking mostly from Accra. The lifestyle in Accra might be different from other places of the country. But yes, we do see a change. Unfortunately, health is often not prioritized by general Ghanaians. And of course, it's also because it's related to finance. We have insurance systems, but most of the time a client will have to pay to go to facility. So even to do random screenings and all those things is not a priority. So we see a change, and unfortunately, I fear it's not going the right direction. So a report is here. It can support us to actually advocate for people's behavioral changes, but also for health sectors change to make it easier for clients to access all kinds of services.
Great, thanks. And I think also, in addition to that, it's so important that we also have the policy environment to be actually conducive to the integration side of things, in terms of actually governments really encouraging the kind of integration of services such as HIV and NCDs through their own policies and plans as well. So I appreciate that we've come to the end of our time, and I don't want to go over. So I'd really like to thank all of our speakers for the excellent presentations and insights that you provided today. Thank you to all our journalist colleagues who've joined from around the world. If you'd like to speak to one of our speakers directly, as I said earlier, please do speak to Michael Kessler at NCD Media Relations to set up a time, and we can put you in touch with the relevant speakers. And as I mentioned earlier, we'll be sending out to all of you the From Silos to Synergies report, along with the press release straight after this call. So thank you again, everyone, and have a good rest of your day. Thank you. Goodbye.